My name is Aimee Seungdamrong. I'm a reproductive endocrinologist and fertility specialist at University Reproductive Associates. IUI actually stands for intrauterine insemination. Inseminations used to be called artificial inseminations and encompassed both intracervical and intrauterine inseminations. We mostly use intrauterine inseminations these days. Intrauterine inseminations mean that we place washed sperm directly into the uterine cavity. The reason why we do this is to potentially improve the conception rate per cycle for patients who have male factor infertility. IUI is also used for the treatment of unexplained infertility. When we use IUI for unexplained infertility, we usually use it in conjunction with ovulation induction. An intrauterine insemination generally improves pregnancy rates per cycle for patients. When we use intrauterine insemination alone, we generally get a pregnancy rate of about 8 to 10% per cycle. When we use intrauterine insemination with clomiphene citrate or other forms of ovulation induction in pill format, then we can expect pregnancy rates of anywhere from 8 to 10, sometimes 12%. Ovulation induction with injectable medications coupled with intrauterine insemination also result in improved pregnancy rates, generally in the order of 12 to 15%. Hysteroscopy is a tool that we use to evaluate the uterine cavity. The hysteroscopy instrument is a camera that we place through the cervix to look directly into the uterine cavity. The hysteroscope can be used to see the uterine cavity. That would be a diagnostic hysteroscopy. It can also be used to remove or improve any problems of the uterine cavity. There are a few things that we look for in the uterine cavity. One is the presence of any abnormalities of the surface of the uterine cavity. These abnormalities can include uterine fibroids, endometrial polyps, adhesions of the uterus, which are scars or scar tissue in the uterine cavity. We also can evaluate the shape of the uterine cavity, and if we do see any of those problems, we can use the hysteroscope with instruments to operate inside the uterine cavity and either remove or fix any of those problems. Diagnostic hysteroscopy is generally done as an office procedure. This is not done under anesthesia. Most patients find it extremely tolerable. We place a small amount of saline into the uterine cavity and then place the flexible office hysteroscope into the uterine cavity to visualize the contents and the surface of the uterine cavity. When we find that there are abnormalities of the uterine cavity that need to be repaired or removed, we perform operative hysteroscopy under general anesthesia in a hospital same-day surgery setting. Hysteroscopy does not require incisions on the abdomen or any instrumentation of the intra-abdominal cavity, and it does not require a lengthy recovery time. Fertility preservation benefits patients who may be going into treatments that could potentially damage their ovarian function. Patients who have cancer, who are about to start a chemotherapy regimen that could damage their ovaries, or patients who are about to have surgery that could damage their ovaries, should think about fertility preservation. There are many ways to preserve fertility. The gold standard at this point is to do embryo freezing. This is best for a couple who would like to create embryos and who would like to use them at a later time to achieve a pregnancy. Other methods of fertility preservation include egg freezing. This can be used without sperm and involves a similar method of retrieving eggs as with embryo freezing, but the eggs are not fertilized before they are frozen. Embryo freezing is a technique that has been developed over many years and has been around for many years, and the technique to freeze embryos is well worked out, and the pregnancy rate continues to improve with each new development. Egg freezing, on the other hand, is something that has been developed more recently. It is still mostly done under research situations, and requires that fertilization be done with a technique called ICSI. The difference between embryo freezing and egg freezing is that embryo freezing is a technique that has been in practice for many years. It is used every day in IVF programs, and it continues to improve with each new development. Egg freezing, or oocyte cryopreservation, is something that has been developed more recently. It is still done mostly under experimental procedures and does not have the same success rates as embryo freezing. Fertility preservation is important because the eggs that are in a woman's ovaries are very delicate. The most number of eggs that a woman has is actually present at the time of their birth. Over time and over their lifetime, the number of eggs in the ovaries decreases with each year. If a woman has cancer or any other disease that requires chemotherapy that could potentially damage the ovaries, what happens is that this decline in the number of eggs increases, and the number of eggs that the woman has decreases much more rapidly. Fertility preservation can be used to harvest the remaining eggs before chemotherapy and hold them until the woman is ready to use them at a later date. Fertility preservation is also important for men who are in a situation where their sperm function or production may be compromised, or they may have to have one or both testicles removed. Fertility preservation is fairly simple for men. It requires the deposit of sperm into a bank, and the sperm is frozen for use later. Sperm that is frozen can be used for any number of fertility treatments afterwards. The most effective way to use frozen sperm when there is a limited quantity of it is to do in vitro fertilization with injection of the sperm into the egg for fertilization. With this method, we only require a very small number of sperm to achieve pregnancy per cycle.